Thank you. Very grateful to get the opportunity to present this work titled Implementation of Low Threshold HCV Treatment in New York State. Data that was collected the year I was the Norwegian Harkness Fellow in Healthcare Policy and Practice and in Comparative Healthcare Research, placed at the Department of Population Science at Weill Cornell Medicine. These are our disclosures. So, hepatitis C virus primarily affects people who inject drugs in high-income countries, such as the US. And to achieve HCV elimination targets, alternative models of care, such as low-threshold models, are required to engage vulnerable population in treatment. So, what is a low-threshold model? Few studies have described the essential features. When asked, people who inject drugs found that comprehensive, patient-centered care that is attentive to their needs and competing priorities would be critical for enabling successful treatment completion. A study by Andrea Jakubowski in 2020 defined low-threshold models of care in regards to opioid use disorder treatments, with the aims to remove as many barriers to treatment as possible. They proposed that the approach be guided by the following principles: same-day treatment entry, harm reduction approach, flexibility, and wide availability in places where people with opioid use disorder go. And even though the term is used frequently, different low-threshold programs, models of care, may have different features depending on their resources and the need of their communities. So, I can't stand here talking about this low threshold in the US without talking a bit about the US. And in the US, a publication from 2021 showed that only 3 states were then on track to achieve elimination by 2030. However, we don't actually know this for sure, as they don't have comprehensive national surveillance data on Hep C. What we do know for sure is that there is no national elimination plan. A lack of universal healthcare system makes low-threshold approaches more challenging to implement. And there's also an insurance restriction for medication access. On the other side, New York State is one of the US states that are leading healthcare elimination efforts and one of 3 states that has an HCV elimination implementation plan. So, we wanted to examine the implementation of low-threshold models for people who inject drugs in delivering HCV care in New York State. We asked, what are the barriers to care and what are the elements in a low-threshold model that address these barriers successfully? So, we conducted semi-structured interviews with 16 healthcare providers in New York between 2021 to 2022. Providers were recruited through investigators' contacts, snowball sampling, and providers were identified either because of self-description as low threshold or a clinical focus on marginalized patient populations. Interviews focused on implementation of low threshold HCV care. Transcripts were analyzed using thematic analysis, categorized into themes guided by the PRISM-REAIM implementation model. However, in this presentation, results are presented based on inductively derived themes. So, in this study, there are 10 different organizations in New York State delivering low-threshold HCV treatment represented. This included community health centers, mobile units, harm reduction programs, methadone programs, and programs included both physician and nurse-led, and most involved peers. These are several of the components included in the low-threshold programs we interviewed. So, now we are going over to the results. So, providers recognize the complexities of providing low-threshold HCV care within health systems that had stricter access barriers, such as stricter appointment times or having security guards to check identification documents. Difficulties coordinating with health insurance and pharmacies, limiting funding and staff availability were identified as major barriers. So, Minimizing the necessary steps to get started on treatment is very important, illustrated by the statement from this provider. We're going to lose tons of people because of all this nonsense that we have to go through to get to the medication. And maybe a reasonable percentage of them would have gotten cured, so that's the balance. It's like there might be that moment where you meet them, where they are motivated. And then finally, when you get their medication, 2 months later, either you can find them or they're not motivated. And by then, they could have been cured. So, the success of low-threshold HCV programs is limited by a failing safety net. And patients are facing barriers in regards to basic needs such as housing, transportation, or a safe place to store their HCV medication. One provider states, "I'm skeptical that elimination will be achieved, and it's in part because we don't believe that people have a right to basic healthcare. We don't believe that people have a right to basic housing. We don't believe that people have a right to basic mental health care. We don't have universal health care, and we, probably at least in the short term, never will. I think Hep C elimination in the United States or in New York is not possible without the full-scale restructuring of our system of healthcare overall." So where do we go from this? Well, some programs tackle competing priorities, as one provider said. I think that our wraparound approach and services is one of the highest. Not only do we focusing on testing and treatment of Hep C, but we also, from the beginning through the process, we focus on any other needs that this person may have, any other social determinants of health that this person may be in need of. And then we make those referrals, and we get them linked and connected to those services as well. One thing that we also found was that adequate staffing is crucial because of extensive care coordination and outreach activities that's needed to engage patients in care. So, one provider highlighted the importance of outreach staff being able to build rapport with the community and bring these services to hard-to-reach areas. Having minimal staff is a barrier because we're not able to do as much outreach. We're not able to go into the communities where people can see us some more and build that trust with them to get them connected to testing and treatment. So, how was low threshold implemented? There are multiple pathways to engage patients. Providers implemented low threshold HCV care by facilitating treatment access, having walk-in or telemedicine HCV services. One provider talks about how other higher threshold providers refer to this program because they know that in fact this program, the lower threshold model program, can get that patient engaged in care. Another provider mentioned telemedicine as an innovative method for implementing low threshold care for underserved population that aren't being engaged in care. And there have been 2 people that I've cured who they never stepped into a building. They never interacted with any clinical space whatsoever, other than the lab that they got taken to do the blood work. But all of the telemedicine visits were done in this person's residence, and they never interacted with a medical facility whatsoever. And I think that's the future. So, low threshold Hep C care can also be another entryway for patients to be engaged in other types of care, increasing overall engagement in healthcare. So, it opens door to them, trusting some type of healthcare worker, getting some blood work somewhere. I do think that is a priority side effect to treating Hep C, as one provider stated. We are getting to the conclusion. So, low threshold models of care enhance access to HCV care and primary care by incorporating logistical flexibility, active patient outreach into their care model. To be successful, low threshold programs need adequate funding for significant outreach activities required to engage their populations. The difficulty of patients meeting basic needs remains a major challenge for delivering HCV treatment. So, a special thanks to my mentors while in New York, Ben Eckhard, Shashi Kabadia, and Bruce Shackman. Thanks to my longtime mentor here in Norway, Ola Dalgard, who introduced me to this field. Special thanks to the healthcare providers who participated, and thank you for your attention.
Thank you so much for the presentation and for the respect of the time. And we don't have questions from the application. Are there any questions from the audience?
And maybe while the mic roves, I have a question if that's okay. Fantastic work. I think, you know, I'm in Canada and we do have universal health care and a lot of these things still ring really true, right?
Yeah.
The clinical appointments via telemedicine being the future, totally agree. Lots of great models out there about, you know, peers and then connecting by telemedicine and so on. Do you know in that particular model, did they have an appointment time still for the telemedicine? Because I think this is also something we're going to need to be more flexible on. Like patients need to be able to call in on their time.
Yeah, I think actually this model had specific times. This was one of the first that started with this, but I'm not sure how that has developed. But I agree with you. I think we have to be flexible and decentralize and be there for the people who need it, so they can access it whenever they need it, timing-wise also.
Thank you.
Thank you. Okay.
Can I ask one follow-up actually then?
Okay.
Sorry. Okay. This was not in your presentation, but how are we going to integrate texting or connecting people via social networks, because that's the only way that they interact with other people, and maybe they're in the library and that's the only time that they have access to the internet because they don't have a phone, that sort of thing. Like, do you think that could be some of these future
Yeah, then we have to
discussions?
give them a phone. Yeah, that's my...
But what do you think about moving beyond like these clinical pathways where we're really rigid about phone only and in-person only? Like, should we be more flexible around texting? I know lots of people do. Sometimes we can only find people on Facebook and that's the only way we can connect with them. Do you think that that could be some future?
Yeah, we have to think innovative and flexible and open door policy. But we can't be open 24/7, but we have to find a way to be reachable when the certain people have this motivation or do want to engage with us. And this is a lot of research needs to be done around that, but so I don't have an exact answer for it. But yes, I agree with you. We need to be flexible and yeah.
Thank you. Thanks for your answers.